Dr. Barry Franklin is the director of the Cardiac Rehabilitation Program and Exercise Laboratories at William Beaumont Hospital in Royal Oak, Michigan. He's also a professor of physiology at Wayne State University's School of Medicine, thank you, in Detroit. We have another woo. He is the past editor of the Journal of Cardiopulmonary Rehabilitation and Prevention and the American Journal of Medicine and Sports, and is the past president of the American Association of Cardiovascular and Pulmonary Rehabilitation, that was in 1988, and the American College of Sports Medicine in 1999. Currently, he holds formal editorial board appointments with 15 different scientific and clinical journals, including these: the American Journal of Cardiology, Chest, Prevention Cardiology, Medicine and Science and Sports and Exercise, American Journal of Health Promotion, and the American Journal of Lifestyle Medicine. He's also the current chair of the American Heart Association's Council on Nutrition, Physical Activity, and Metabolism. Dr. Franklin and his associates have studied the hemodynamic and cardiorespiratory responses to numerous occupational and leisure time activities. Other areas of research, his research interests include primary and secondary prevention of heart disease and the risks associated with sporadic high-intensity exercise. Dr. Franklin has written or edited more than 500 publications, including, yeah, it's a lot, 375 research papers, 77 book chapters, and 27 books, including his newest one. You can find this at the ACSM store right out there. And I'm sure if you pick up this book, it's called The Heart Healthy Handbook, Written to Help Patients Help Themselves. I'm sure if you get this book out there in the ACSM store, Dr. Franklin will sign it. It is my great pleasure and an honor to introduce to you Dr. Barry Franklin.
Good evening. Thank you for the very generous comments, Walt. I'd also like to thank Mike and the program committee for the opportunity to give this opening keynote. When I think of introductions, I oftentimes think of the time that I flew 22 hours one way to Thailand and 22 hours back to give a 30-minute talk. True story. And it was another nice introduction. And at the end of the talk, my wife came up and said to me, "Dear, I figured out something about you after 43 years of marriage." And I said, "What's that?" She said, "I figured out why you'll fly here, fly there, stay up half the night shifting those ridiculous slides." And I said, "What's the point, dear?" And she said, "I think you'd like to hear yourself introduced." Anyway, it's an honor and a privilege to be here. I put this talk together, and it's a unique talk. I put this talk together as if practitioners came to the office, and the most common questions that I'm asked, I tried to address in this particular talk over the next 50 minutes. I hope it'll be helpful to you. I once had a great mentor who said, if the talk is really going to hit the mark, you've got to entertain, you've got to inform people, and they've got to take away some new enlightening things that they didn't know before, and that's my objective this evening. Welcome to the good old US of A. Only here do you see scenes like this. And oftentimes people are multitasking, and when you're multitasking, you're very inactive. This I got off the internet, sedentary seduction. Instead of standing in line, you sit in the chair, moves right now in the Japan, but coming to the United States. These are the challenges that you and I face on a day-to-day basis. As I developed this talk, I thought initially of the activity pyramid by Mozaffarian, in which at the bottom of the pyramid, he highlighted the fact that we have lifestyle factors, including poor dietary habits, physical inactivity, and cigarette smoking, which ultimately lead to novel and established risk factors, inflammation, early vascular disease. The clinical endpoints that you see here, by the way, that's the cross-section of a coronary artery of a 37-year-old woman. who unfortunately died of a massive MI, and then ultimately death. Coronary disease is the major killer and crippler, but at the bottom of that pyramid is something you and I deal with on a day-to-day basis, and that is physical inactivity. Over the next 45, 50 minutes, I'm going to highlight for you some key benefits and limitations of physical activity in the prevention and treatment of cardiovascular disease. I want to open up with this sobering fact, that is Thomas Jefferson, our third president, lived to be 83 at the time the average age was about 40 at death. But interestingly enough, Thomas Jefferson walked 4 miles every day. It was an early case report. People were amazed by that information. But I've been on the other side with reviewers over the years who said, how do you know it's causation versus association? In other words, the critics have said, well, maybe people walk more or faster because they're healthier. Or are they healthier because they walk more or faster? I believe it's the latter. And I'm going to come back to this point because the critics over the years have said, we need randomized controlled trials, RCTs, if we're really going to know the benefits of exercise. I want to leave you with my last slide on that particular topic. So that's where we'll end today. I'm going to cover 5 topics. We'll start with physical activity, fitness, surgical outcomes, mortality, protective mechanisms, go to moderate versus high-intensity training, extreme exercise, accruing physical activity. Here I'll share with you some new data that I think you'll find rather sobering. And finally, high-risk activities. This is a paper we wrote 2 years ago for the American Journal of Cardiology. Reduced walking speed and distance as harbingers of the approaching Grim Reaper, and what we highlighted is the following. Numerous studies now suggest that gait speed, simply looking at your client or patient's walking speed in and out of the gym, offers a foretelling future of their health outcomes over time. They are indeed powerful predictors of mortality and future cardiovascular events. You say, show me the data. Here are some data that got my attention. First one published back in 1998 in a decent journal called the New England Journal of Medicine. They looked at 707 non-smoking retired men, 61 to 81 years of age. They looked at the distance walked per day. 12-year follow-up, nicely done, 208 deaths. But the results were sobering. They found the mortality rate among men who walked less than a mile a day was nearly twice that those who walked greater than 2 miles a day. The conclusion, regular walking associated with a lower overall mortality rate in older, physically capable men. Whenever I give this in a cardiology grand rounds, invariably a cardiologist says, well, show me the data. Here are the data. If you like to look at graphs, this is what the graph looks like. These are the men who walked less than a mile a day, the highest death rate. These are the men who walked 2 miles or more per day. One of the early studies to suggest that simply walking patterns in older adults have strong prognostic value. This study got worldwide attention, done in Australia. They looked at older men, they looked at their usual walking speed, and the results were sobering. They found a walking speed less than, of 2 miles an hour or less was most predictive of mortality. So I simply say, if you're walking and I see patients walking in and out of the place like so, that's indicative of the highest mortality, whereas 3 miles an hour, which is just about so, indicates individuals who didn't die during that follow-up period. This study got worldwide attention because it suggested that simply gait speed could be a strong prognostic indicator. This was a study done in the kind of patients I deal with on a day-to-day basis. Patients with coronary artery disease, the Heart and Soul study, 556 patients followed up over an 8-year follow-up period. They asked them to do a walk for 6 minutes, the most distance they could cover in 6 minutes. Look at these data. Those heart patients who had the lowest distance covered in 6 minutes clearly had the highest rate of heart failure, myocardial infarction, death, and any event. And those who covered the fastest speeds, the most distance, look at the difference in heart failure over a 6-year period, in myocardial infarction, in death, and any event. As a result, I work in a hospital. I've worked in hospitals all my life. I tell our doctors, our residents, and cardiology fellows, simply look at the patient's pace as they walk in and out of the waiting room, because that could be, in fact, your most significant and telling vital sign. Dr. Bob Salas, who's going to give the closing lecture, has been the champion saying we need to incorporate some indices of physical activity or fitness as a vital sign, and he's absolutely right. A tortoise-like pace may in fact provide the most telling vital sign of your physical exam that day. We also look at maximal oxygen consumption. We measure it, you measure it, you're certainly familiar with it. We assess it in terms of what's called METs, or metabolic equivalence. The landmark study done by Kodama and colleagues, clearly published in JAMA 2009. This is a very busy slide. I made it very simple for you. Simply look at this number right here, 0.85. That basically said that for every 1 MET increase in the patient's exercise capacity, there was a corresponding 15% reduction in acute coronary events over time. That's a telling prognostic indicator. This is an article we wrote in the Journal American Medical Association, but strictly on cardiac patients, and we came to the same conclusion. But for those of you who are involved in clinical medicine, it has tremendous ramifications, because we found that in patients with coronary artery disease, each 1 MET increase is associated with about a 16% reduction in mortality. That compares very favorably with the survival benefit conferred by low-dose aspirin, statins, beta blockers, and ACE inhibitors. I oftentimes say to fellows or residents, how many of you recommend aspirin after a heart attack? How many recommend beta blockers? How many recommend statins? Everybody raises their hand. I say, how many recommend regular physical activity? Here are the data. I'm not saying throw the aspirin, statins, beta blockers out the door. I'm saying complement them by getting your patients to increase by 1 MET or 2 METs additionally, and you can expect an additional 32% reduction in mortality. This is a great story. Every young cardiology fellow who works at Beaumont's got to spend a month with me in cardiac rehabilitation. I remember seeing a fellow the first day, and he clearly didn't want to be there. He wanted to be in the cath lab doing angioplasties, far more sexy than being in the cardiac rehab program. They made it very clear to me that he didn't want to be there with me. And I tried to make conversation the first day. And I remember saying to him, Dr. Dutcher, what's the best index of prognosis after a heart attack? And he looked at me, and I'm the mentor, and he said, that's a stupid question. I said, what's the answer, Dr. Dutcher? He said, everybody knows the answer. I'd much rather be in the cath lab than in this rehab program. I said, what's the answer? He said, left ventricular ejection fraction, which tells you the percentage of blood ejected per each beat. And I replied, do you ever think about looking at METs? To which he replied, what are METs? I said, Dutcher, you need to spend some time with us in the cardiac rehab program, find out a little bit about METs as they apply to clinical cardiology. I remember vividly, Dutcher could run circles around me with statistics, with a computer. He was an idol of a lady by the name of Cindy Grimes, who ran a big PAMI database. These are all patients who had angioplasty in the setting of acute myocardial infarction. He got a hold of the database, and he calls me one day and he said, you know, I'm going through Grimes' database, and I know what he was looking for. He was looking to show me that ejection fraction was the best indicator of prognosis. And he said, we got a lot of these patients that had a cycle ergometer. I said, yeah, go ahead. I said, cycle ergometer? Yeah. And he said, they've all got this kilogram meter per minute workload. Can you convert that to this METs? I said, yeah. Do you have body weight on the people? I said, yeah. And I didn't hear from him for about 2 weeks. I gave him a formula so he could convert it, so he could look at Grimes' database. And I'll never forget, I got a call on a Saturday one time, and I picked up the phone, He said, Dr. Franklin, this is Jake over at the hospital. I said, yeah, what are you doing? He said, we got something big here. I said, what's that, Jake? He said, this METS is a much better predictor of mortality in Brian's database than his left ventricular ejection fraction. To which I replied, isn't that remarkable, Dr. Dutcher? Got a big finding. He published that in the American Journal of Cardiology with Dr. Cindy Grimes. And Dutcher's conclusion was exercise capacity, a better predictor of 2- and 5-year mortality than left ventricular ejection fraction in patients with STEMI, ST segment elevation MI, treated with percutaneous coronary intervention. For those of you who want to see the data, here are the data. Less than 40%, greater than 40% ejection fraction. The real modulator here was less than 4 METs. And you can see patients with less than 4 METs, less than 40% ejection fraction, had the highest mortality rate. I had a long day. I was heading in this direction, and I got to tell you the truth, I was heading to the right. And all of a sudden, I saw something scratched on the floor, and as I got closer, I saw this, and I made an abrupt left. Goes to show you that sometimes your environment can change your behaviors. But the major point I want to make here is that this reminds me of the relationship between fitness, fatness, and mortality, published in the Journal of American Medical Association by the guys at the Cooper Clinic. Here they looked at 25,000 men, an 8-year follow-up period, and they divided them into normal weight, overweight, and obese. Look at these data. Basically, regardless of whether you're normal weight, overweight, or obese, what you see is that unfit individuals were about 3 to 4 times more likely to die in follow-up than their fit counterparts. What blew my mind on this slide was the fact that the difference between being fit and unfit actually appeared to be greater than the difference between being a smoker or non-smoker for each one of those cohorts. They concluded this landmark study by saying, although physical activity, exercise training is not going to make all people lean, appears an active way of life has important health benefits, even for those who remain overweight or obese. It's a question I ask our patients all the time. If there were a pill that you could take to cut your risk in half of dying from cardiovascular disease over the next 30 years, would you take it? There is such a pill. It's called regular exercise or physical activity. That was glaringly showed in this landmark report published in 2014, Cooper Clinic database, Dallas, Texas. About 25,000 men and women, varied coronary risk factor profiles. But regardless of the risk factor profile in men and women, and here's men who are disasters, positive in every risk factor, here's women who are disasters, but regardless of the risk factor profile, what you see here is this. Low-fit men and women had approximately twice the mortality rate as their higher-fit counterparts. What also blew my mind in this slide is that if you can get to the age of 40, 45 without any major risk factors, your likelihood of developing cardiovascular disease over the next 30 years is about 5 to 8%. We talk about the benefits of physical activity. I believe they're anti-atherosclerotic, anti-ischemic, anti-arrhythmic, and anti-thrombotic. If you said to me, Barry, pick one of those, what do you think is really most important, why fit people live longer? I would say it's probably this one, anti-arrhythmic. Increased vagal tone, decreased adrenergic activity, increased heart rate variability. A study just came out on patients on beta blockers, and they found if they're taking beta blockers after a heart attack, for every 10 beats, the resting heart rate is lowered, their cardiovascular mortality rate is reduced by 30%. For every 10 beats, it's lowered. One of the hallmark effects of physical training is a lower resting heart rate, oftentimes 10, 15, 20 beats. What about healthcare costs? This is such a hot topic. Dr. John Myers and his colleagues looked at, in the VA at Palo Alto, looked at exercise capacity and subsequent healthcare costs. And what did they find? Those who had less than, how many met capacity? I can't read that. Somebody read that for me? We're going to come back to that number time and time again today. Less than 5 met capacity, which means they can't do stage 1 of the Bruce treadmill protocol, 1.7 miles an hour, 10% grade. Those have very, very high healthcare costs. And those, as the fitness increased, healthcare costs almost half those of less than 5. Once you get up to 8 or 9 mets, somewhere around $5,000 per year. How about fitness as an index of prognosis after surgery? We were doing bariatric surgery at our hospital, and to be quite frank with you, 15 years ago, we had a lot of deaths early on. And I remember the person in charge, young cardiologist in charge of screening these obese patients, said to me, "Barry, I want you to start doing stress tests with VO2 on every obese patient who's going to undergo bariatric surgery." And I remember saying to him, "Peter, a lot of your patients are 400, 500, 600, 700 pounds. How are you going to do them? The treadmill only goes up to 500 pounds. He was very nice, typical young cardiologist. He said, "You're in charge of the stress labs, you figure it out." We did. We used a new step. We could put 400, 500, 600, 700, 800-pound people on that new step, and we did stress testing on them. We looked at people whose average age was 49, BMI range 36 to 90, average BMI 49. So we're talking about big people. And Dr. McCullough had a theory. And he said, "I think people who are fitter are going to be less likely to die after bariatric surgery." I said, "Peter, you're crazy as hell. I don't see any, what's the relationship there?" He says, "I think they're going to be able to better tolerate the stress of major surgery." Peter was right. I was wrong. And what he showed is that if those obese patients came to us with less than 15.8 ml per kg per minute, which is about 4.5 mets, their complication rate from bariatric surgery was 17%. Those above 15.8, what was it? I can't see that. 2.8. That changed medical practice in our place. And they said, "There's no urgency for people to have bariatric surgery. You got to start walking, you got to start losing weight, and then we'll do your bariatric surgery at Beaumont." And the surgeons loved it because all of a sudden the mortality rate decreased, plummeted. That's an example of practical research. We did the same thing with bypass surgery. We went to Dr. Sacco, although bypass surgery, very, very good, but we said we think we might be able to identify another factor in those who don't do well with bypass surgery. We identified about 600 patients who had stress tests within 3 months of their bypass surgery. We did bypass surgery, then we looked at outcomes. Look at this. Specifically, low preoperative cardiorespiratory fitness, less than how many mets? 5, associated with much higher operative 30-day mortality after bypass surgery. Say, "Show me the data." Here are the data. Here's 30-day, here's operative mortality, here's prolonged ventilation, horrendous long-term prognosis in those less than 5 mets. It's a big push right now, and we're starting at our place, where people before bypass surgery are now coming to cardiac rehab to raise their fitness level, to get them in better shape to tolerate that major surgery. It's called prehab. Topic number 2, continuous moderate versus high-intensity training. What do you need to know here? Traditionally, we've exercised people at around 70%. More recently, some Europeans have taken people up to 90, 95% for short periods of time. Is this superior? The landmark study was this one, done by Wisloff and colleagues. They looked at 27 post-infarction patients. They were older patients, age 75, had compromised ejection fractions, low VO2 max, less than 4 mets, randomized to continuous training, that is at 70%, or high-intensity interval training, 95%, versus a control group. What did they find? In terms of endothelial function, a good index of coronary function, the controls showed virtually no change. Moderate continuous training, nice improvement here in endothelial function, but slightly better improvement here in maximal oxygen consumption. and the high-intensity aerobic interval training, the biggest improvement in endothelial function, blood vascular function, as well as maximal oxygen consumption. So I have no doubt that high-intensity training is more efficient in terms of improving VO2 max, better improves blood vasculature, but there's no question in my mind for older individuals who may be at high risk, it could also be more likely to trigger acute coronary events. I think they summarized it best in this review when they said, in patients with coronary disease, interval training appears more effective than continuous training for improvement in aerobic capacity and endothelial function. Long-term studies assessing safety, compliance, and morbidity and mortality following interval training are needed before this approach can be widely adopted. I, for one, don't want to take high-risk patients or patients with known coronary disease and send them out to the YMCAs around the country and say, we want you pushing at 90, 95%, because they may have underlying heart disease and it could lead to a rash of complications. And we have no data to suggest that they actually live longer as a result of that high-intensity interval training. So right at this moment in time, I think additional data are needed, but I'm not on the bandwagon for it, at least in high-risk older individuals. Topic number 3, extreme exercise is better. Not necessarily so. There's a reverse J-shaped curve that many of you may not be familiar with. Is it possible to get too much of a good thing? LaGersh in Australia said, in effect, exercise may have a typical dose-response curve with toxicity at more extreme levels. The study got worldwide attention, 27 athletes competing in a triathlon. What they found was sobering. Increase in cardiac troponin, we see that in the setting of acute myocardial infarction. BNP, we see that clinically in the setting of heart failure. In the immediate post-race setting, they had echocardiographic abnormalities of right and left ventricular function. The significance cardiac injury seen after intense exercise represents a potential for generation of scar tissue, and which ultimately could lead to malignant arrhythmias. Study we did at Beaumont, published Journal of Applied Physiology, one of our talented cardiology fellows. Took 25 marathoners, average VO2 max 54 ml per kg per minute, average age about 38, 39. Did cardiovascular MRI on them before running in the free press marathon and afterward. What did he find? Marathon running caused dilatation, big overload of the right heart, right atrium, right ventricle, reduction of the right ventricular ejection fraction, release of cardiac troponin, which we see in the setting of acute myocardial infarction, and BNP, but did not appear to result in any lasting ischemic injury to these chambers. I think Kim, just weeks ago, summarized it when they said, yes, light to moderate exercise is good, more extensive exercise may be better, but yet we're seeing some studies that suggest loss of mortality benefit, atrial fibrillation, pathologic cardiac remodeling, and a worsening of coronary atherosclerosis. I want to focus for this purpose on this study alone, loss of mortality benefit. Study got my attention, cardiac patients. Over 1,000 patients studied over a 10-year period of time. These were all heart patients, and they looked at their training regimens. What did they find? If we look at cardiovascular mortality and all-cause mortality, which subsets had the highest subsequent mortality? Well, not surprising, it's those who rarely, if ever, exercised. They had the highest mortality. Who had the lowest mortality in these cardiac patients? Those who exercised 2 to 4 days a week. And interestingly enough, those who exercised at high intensity daily had about double the mortality of those who exercised 2 to 4 days a week here, and double the all-cause mortality here. One study. So let's not get too upset. Then Paul Williams published this in the Mayo Clinic Proceedings. 2,300 cardiac patients studied over a multi-year period of time. In a nutshell, what you see here is, once again, what's called a reverse J-shaped curve. In general, the more exercise they did, the lower was the subsequent mortality up to a point, whereas beyond that point, those doing high-intensity exercise had about the same mortality as those who were doing little or nothing. That was echoed in this Copenhagen City Heart study in healthy people, in which they found a U-shaped association between all-cause mortality and dose of jogging. Light and moderate joggers have lower mortality than sedentary non-joggers. That's not news. Whereas strenuous joggers have a mortality rate not significantly different from that of the sedentary group. The new mantra is exercise is medicine. To me, that indicates there's probably indications and contraindications, but underdosing and overdosing may be possible. Here you clearly see that compared to sedentary individuals, light joggers, moderate joggers had lower mortality, whereas strenuous joggers, and admittedly the deaths here in smaller numbers, 36 and 2, but virtually no difference as the sedentary people. As a result of all these kinds of things, the American Heart Association asked Paul Thompson and I several years ago to chair a committee talking about the risk of exercise. And here we highlighted the fact that when we see an 18 or 19-year-old die suddenly, almost invariably it's a structural cardiovascular abnormality, most notably hypertrophic cardiomyopathy, whereas in older people, it's typically clogged coronary arteries, that is coronary heart disease. We now know that exercise, vigorous exercise, can lead to a cascade of physiologic responses that ultimately can increase myocardial irritability, ischemia, which can be highly arrhythmogenic. We also recognize that sudden cessation of exercise when myocardial demands may still be high in the presence of coronary disease can further exacerbate ventricular ectopic activity. That's a stress test that was done in our lab not too long ago. And what you see here is very significant ST segment depression indicating myocardial ischemia as a forerunner to this run of ventricular tachycardia. We also now know that vigorous exercise in some people can cause plaque rupture, which causes acute myocardial infarction and thrombosis, and that's a stress test in our lab that went bad. And what you see here, by the way, this is not right bundle branch block. That's not early repolarization. That's ST segment elevation MI indicative of acute myocardial infarction. The good news is we saw that. He had chest pain. We shipped him to the cath lab, and we were able to literally halt the heart attack in progress. Today, there are no Q waves on his EKG. This guy looks great because he was at the right time. He was at the right place at the right time. 2009, we set a world record in Detroit. My city, busy day for me. They said, aren't you the guy who says exercise is good? We had 3 guys drop dead within 15 minutes of each other. 3 guys dropped dead. The average per year, by the way, is about 4 marathons all around the country, so it's not a high risk event. But we had 3 die in one day. As a result, we became very attuned to trying to identify this. And I was taken back by this quote: cardiology community is faced with the challenge of providing an inexpensive, sensible screening strategy for the prevention of sudden cardiac death while reaffirming the benefits of moderate to vigorous exercise outweigh the potential risks. We started the Beaumont Cardiovascular Performance Clinic modeled after the one at Massachusetts General in Boston. And it's been a huge success. People can refer themselves. They walk in with a check, so we're not waiting 6 months for Blue Cross or Medicare to send us a check. And it's patient pay. Here's what we do, basically. All come in for the following test: history and physical exam, 12-lead ECG, echo, exercise stress test with VO2 max, anaerobic threshold. If they're over 40, we get coronary calcium score. The way it's set up, they come in for the echocardiogram. If the echocardiogram is normal, we go ahead and do a max stress test for VO2 max. Then we sit down and meet with them to review their cardiopulmonary exercise test results, and then the cardiologist reviews the coronary calcium score, the ECGs, and the echocardiogram. They're out in 2 hours and 15 minutes. People love it. Topic number 4, 4 out of the 5, accruing physical activity beyond structured exercise programs. What's new? What do you need to know from a practical standpoint? My own bias, and you may disagree, is the traditional program. That is driving to the gym, packing your gym bag, going in the locker room, changing, exercising, and then going home after that has been only marginally effective. Exercise professionals should consider broadening clients' recommendations from gymnasium work per se to promoting increased activity in daily living. And I would contend they could burn more calories in 16, 17 waking hours during the day than they do in the gym. We actually photographed our people in the gym who were there for 1-hour sessions. We monitored them by video. They're there 60 minutes. How many of those minutes are they actually exercising? 32. 32. Almost half the time they're spent charting, talking with somebody else, and so on and so forth. Some people spend more time in the car getting to and from the gym than they do actually exercising in the gym. So we need to think of getting them more involved in our prescriptions in day-to-day activities. I love these kinds of things, and if you're in San Diego and you haven't walked by the water downtown, it is the most wonderful walking, jogging path. They really were way ahead of the game in terms of setting up this city. Pedometers can also be very beneficial, and a decade ago, Bravada published in JAMA the fact that just wearing a simple pedometer sensitized people so on average they took 2,500 more steps per day. We can use accelerometers, we can use a variety of technologies to get people more physically active. Here's something that I think will blow your mind. This was a study done by the National Health and Nutrition Examination Survey in which they looked at adults all over the country, and these were, to me, were sobering. Trade-off of sedentary time with light activity was associated with a lower hazard of death. Interventions that replace sedentary time with an increase in light activity of about 2 minutes appear to confer a substantial survival benefit. 2 minutes, I tell her, 2 minutes an hour, get up at least. That has a big impact if done over an 8-hour workday. This also got my attention because a lot of people, including myself, have been saying you can break up exercise into 10-minute bouts instead of 30 or 40. Think of 10-minute bouts. There's lots of studies now that suggest they can even be shorter than 10-minute bouts, particularly if it's moderate to vigorous exercise. In this study of the Framingham database, our cross-sectional observations on large middle-aged community samples showed a positive association of moderate to vigorous physical activity with healthier cardiovascular risk factor profile and indicated that accruing physical activity in bouts less than 10 minutes may favorably influence cardiometabolic risk, supporting the public health promotion message that every minute counts. I tell my patients, small changes, 1 minute, 2 minutes here, over time, big impact. Last topic, high-risk activities. To be objective, we've also got to look at activities that can potentially trigger acute coronary events, because I'm asked this all the time clinically. Can I do this or can I do this? 3 activities that I think I want to sensitize you are the following. In my role, I got in the habit, unfortunately, of reading the obituary columns on a regular basis. And I remember picking up the newspaper one day and seeing somebody who I knew, not really well, but who I knew. I said, this is a young guy. I said, how could this young guy drop dead? I knew he was physically active. He's 55. Then I read the obituary column. Mark Janke died of a heart attack Wednesday while playing racquetball at a local club. He was 55. I'm not condemning racquetball, but I'm saying racquetball for people 55, 60, 65, 70 who may have underlying coronary disease is not like walking on a rated treadmill or pedaling a cycle ergometer. It's based on competition, stop, start, high-intensity aerobic, and you're trying to beat somebody else. Then I said, I wonder if there's any reports in the literature on racquetball. And I uncovered this. Sudden death and vigorous exercise, a study of 60 deaths associated with squash rackets. So when I got a high-risk patient who's in his upper 50s, 60s, 70s, and he said, I want to go back to competitive racquetball, I'm a little bit hesitant in saying, yes, that's fine, you can do that. The other topic that got my attention was this one, snow shoveling. I lost two dear friends, a department chairman at the University of Michigan and a physician at Penn State who I work with, both of whom were shoveling snow, and nothing really clicked. Nothing really clicked. I assumed it was a coincidence until I picked up the paper in Detroit one day, years after I had left both schools, and it read the following. At least 8 people died Wednesday in the Detroit area after snow-related exertion. Wayne County, 17 heart attack deaths were attributed to exertions since the snow began Tuesday. Most of the victims were older men clearing their walkways and driveways of snow, and a light bulb went on. And I said, wow, this activity may be dangerous for some people. And then I went to our Human Investigation Committee and remember presenting years ago and said, I want to study 60, 70, 80-year-old guys shoveling heavy, wet snow on the grounds of Beaumont Hospital. I saw a lot of blank stares, including a couple physician members. And they gathered and they chatted for a while, and they came back and they said, we like the idea, but we want you to use a different population. I said, what's that? They said, healthy guys under the age of 35 and extrapolate the data to older people, because they didn't want anybody dying on our hospital grounds. We did the study. We published it in Journal of American Medical Association, and then we did 2 studies after that, which really got a lot of attention. This first one, however, really was enlightening. We went out in the grounds of Beaumont Hospital, and I remember saying to the grounds crew, I'd like you to take those mounds and spread them out on the parking lot about 4 inches. And they said, Dr. Franklin, we normally push all that stuff to the side. We build them up in big piles over here. I said, well, we're going to do a study, and we want to see what heavy, wet snow does in terms of the cardiovascular responses. I said, okay, we can do it. And then what we did is we measured oxygen consumption. We had an EKG. We had blood pressure measurements. And then at the same time of day, we did a maximal treadmill test for comparison purposes. Look at these data. Maximal treadmill testing, heart rate 179, 10 minutes of snow shoveling at their own pace, 175. Systolic blood pressure, 181, immediately after snow shoveling, 198. Rate pressure product, a key index of myocardial oxygen demand, actually higher than was maximal treadmill testing. Here's the problem. METs here, 5.7 versus 9.3. So the usual signs of overexertion, sweating profusely, out of breath, they weren't while they were shoveling snow. They had no idea that their heart rates and blood pressures were equivalent to or greater than maximal treadmill testing. So what you get here is what's called a disproportionate myocardial to body oxygen demand. Different study we did. Pertha Chowdhury was a cardiology fellow. He said, has anybody looked at the deaths that occur in the Detroit area? Well, what Pertha did is, after 2 major snowfalls, went to the county coroners and identified everybody who had died days before or after or during major snowfalls in Detroit. And what he found was, of all the deaths, 33 men and 3 women were involved in snow removal. That's just in the Detroit area. The week before the storm, there were 2 exertion-related deaths. The week of the storm, 24 exertion-related deaths. And the week after the storm, when people were still cleaning up, 17 exertion-related deaths. There's no question in my mind that snow shoveling can be a trigger for acute coronary events in older individuals with known or hidden heart disease. As a physiologist, I oftentimes get the question, what is actually the mechanisms? Before I do that, I will highlight for you the fact that occasionally an obstinate patient will say to me, I don't care, I've been shoveling snow all my life, I'm going to continue to shovel snow. And I said, that's fine, make sure you get a top-of-the-line snow shovel. They said, what do you mean? I said, one equipped with defibrillation pads, because your wife may have to resuscitate you. Here's the 5 factors that are involved. As George Clooney would say, it's a perfect storm. The relative inefficiency of arm exercise compared with leg exercise. If I take any one of you, have you crank an arm ergometer with your arms, and then have you pedal the same workload with your legs, you're going to have much higher heart rates and blood pressures with your arms. Working in an upright position when the legs are frequently motionless. The blood is needed back in the head and the heart. When you're walking on a treadmill, you're promoting venous return, but when you're standing still, that blood pools in the lower extremities. It's a prescription for disaster. Not to mention isometric exertion, expiratory Valsalva maneuver, and the inhalation of and exposure to cold air, which causes those arterioles throughout the body to constrict, raising blood pressure, and also causes those coronary arteries, which are about the size of cooked spaghetti, to constrict as well. It's not surprising that you got a lot of deaths every year during that activity. How about deer hunting? At least in Michigan, we got a lot of deaths every year during deer hunting. We took 25 deer hunters, we Holter monitored them, we asked them to keep a diary, and then we did a stress test on those same deer hunters. What do we find? Deer hunting can evoke sustained heart rate increases, ischemic ST depression, threatening ventricular arrhythmias in excess of those documented during treadmill testing, strenuous nature of deer hunting, coupled with presumed hyperadrenergic response, superimposed environmental stresses contribute to the cardiac demands. Here's an ECG sequence that's going to blow your mind. Let me make it very clear that this was a deer hunter who never moved. He was standing next to a tree, but as he looked out in the field, about 100 yards away, he saw a deer. And that heart rate at 63, 64 suddenly started to go up. What you see here is artifact in the ECG, because that's where he's actually pulling the trigger. And he saw the deer drop, and what happened? It still hadn't moved. Heart rate was now 170 beats a minute. I oftentimes say, don't show this to the cardiologist. They'll get a test faster than the Bruce test to get the patient's heart rate up. Just show the deer hunter a picture of a deer, and he'll get his heart rate from 60 up to 170 in about a minute and a half. This gives you some idea of the tremendous demands on the heart that can occur with cold, hyperadrenergic response, and so on and so forth. And a lot of these guys, to be quite frank with you, are habitually sedentary, and they go out once or twice a year to deer hunt. They're eating heavily, they're drinking, they're wearing heavy clothes, they're climbing up hills, they see the deer, all this superimposed. Here, in fact, is one deer hunter who saw a deer and his heart rate got to the same level as he got during 100% of his maximal graded exercise test, and when he was walking and dragging the deer, he was 15, 20 beats higher. What do I want to leave you with? Last 9 slides. Extreme endurance exercise is not for everyone and may be associated with cardiovascular events. The WW there is to remind me to say, where's Waldo? Sometimes you look at a picture and you wonder, where's Waldo? There's 2 very famous people in this picture. If you look at the very top, that's Oprah. And right here, that's President Bush in a marathon. But the fact of the matter is, marathons, distance races may be associated with acute cardiovascular events. Out of every slide I'm going to show you, this next one I think is the most important, because it will help you answer questions that I've gotten over the years. It was published by Dr. Murray Middleman at Harvard a few years ago and explains this apparent paradox between sedentary, active, and the risk of acute coronary events. Let's first focus on the bottom portion of that slide, and what you see as you compare the sedentary versus the active, you can see the sedentary person overall, over the entire day, is at higher risk for an acute MI. Some studies suggest up to 50% higher, point number 1. Point number 2, when that physically active person goes out and does high-intensity work, his or her risk does increase but it only increases to the point that it's about the same as the sedentary person at rest. Who's at greatest risk? It's the habitually sedentary person who goes out once a year or once every decade to decide he's going to play racquetball with his son-in-law because he used to be a good racquetball player, but he hasn't played in 30 years. They're going to go to the Y and we're going to have a great match. Or the guy who's habitually sedentary gets a big winter snowstorm and decides he's going to go out, he's got to clear his driveway of snow. Those people are at greatest risk. And using these data, Deb Beebe spearheaded a group, and Walt Thompson was very supportive and involved with the group, to change some of the pre-participation screening guidelines. And something in that new document and in the new guidelines is this, which is very, very important. When previously sedentary individuals initiate an exercise program, level walking, 2 to 3 METs, should be strongly recommended. You don't go out and start jogging or walking up high hills the first day. Gradually increasing the speed to 3 to 5 METs, which could be a speed of 4 or even 4.5 miles per hour, over time, 2 to 3 months, provided that the individual remains symptom-free. If they begin to develop symptoms at 3 miles an hour, 3.5, have them stop and get medically screened. Those people need screening if they're developing symptoms. This strategy will decrease injury, increase fitness, without going through periods during which each bout of vigorous exercise is associated with big spikes in relative cardiovascular risk. Cardiologists refer to this as the progressive transitional phase. Progressive transitional phase. Don't let habitually sedentary people start jogging or great at treadmill walking. We also studied in a well-known health club people who had cardiac events, and basically what we found also is that those who had cardiac events almost invariably had attendance that was usually once or twice a month or less. So sometimes it'd be 2 months, they hadn't been there, they want to get their money's worth, they walk in, say, I haven't been here in 2 months, I'm going to put the treadmill up at 7, 8 miles an hour and start jogging. Those are the people who run into problems. So there's great practical messages here. Finally, the rule of 5 and 10, and I've inferred this throughout the entire presentation. Who gets the greatest benefit out of an exercise training program? It's not the woman who says to me, Barry, I'm doing 50 miles a week, I'm starting to train for the Free Press Marathon, I'm going to go to 75 or 80 miles a week, I'm going to get better performance, and I'm going to be healthier. My answer is you may get a little better performance, but your survival, your health is really not going to change very much. No, it's the person who's in the bottom 20%, the least fit, the least active cohort. Study after study after study has shown that. Get those people doing something, and there's a huge drop in mortality. What is that level? Once again, it's less than how many METs? 5, which means they can't do, this is not training, this is max treadmill testing. If they can't do 5 METs on a treadmill test, those people are at greatest risk. It's one of the reasons why in our lab, one of our big goals for new people is to get them training routinely at 3.5 METs. Because if they can train at 3.5 METs or higher, I know they got more than a 5 MET capacity if they're giving me an RPE of 11 or 12 at 3.5 METs. So the biggest bang for your buck, getting them out of that bottom 20%, which means they got less than a 5 MET capacity. What's the other end? Interestingly enough, study after study after study has shown that that upper limit is around 10 METs. That is stage 3 of the Bruce Treadmill Protocol, 3.4 miles an hour, 14% grade. So if somebody says, I want to get to the lowest risk, highest fitness compatible with lowest risk, my answer is if you can get to training at 7, 8 METs on a regular basis. I know you got over a 10 MET capacity and you're in that golden group. 10 METs. This was a fascinating study by Mike Lamont and colleagues at the Cooper Clinic. Look at this. Participants, 710 asymptomatic men from the Aerobics Center longitudinal study whose fitness was quantified as less than 10 or greater than or equal to 10 METs, whose coronary artery calcium score was greater than 100. Clinically, that means these guys got underlying coronary disease. That's the early stages of underlying coronary disease. During 3.5 years of follow-up, 59 events occurred. Look at this. The age-adjusted hazard ratio of coronary events was 0.26 right here in men whose fitness was greater than or equal to 10 METs compared with those whose cardiorespiratory fitness was less than 10 METs. So there's something special about 5 METs and getting above 10 METs in terms of maximizing your long-term survival or risk. I started 55 minutes ago with a question to you, and that is, the critics say we need randomized controlled trials. Is there a need for randomized controlled trials? I found this article that I want to share with you in closing, and it's titled Parachute Use to Prevent Death and Major Trauma Related to Gravitational Challenge. Systematic review of randomized controlled trials. These investigators said we were unable to identify any randomized controlled trials of parachute intervention. As with many interventions intended to prevent ill health, the effectiveness of parachutes has not been subjected to rigorous evaluation by using randomized controlled trials. We think everyone might benefit if the most rational protagonists of evidence-based medicine organized and participated in a double-blind, randomized, placebo-controlled crossover trial of the parachute. I contend the same rationale for physical activity. Thank you very much.